Hello again and welcome to another session of the Center for Podiatric Education. In this session, I'd like to continue with a series of lectures that we have presented evaluating the role of the podiatric physician in the evaluation and management of the older patient, the geriatric patient. We know that this is a rapidly expanding population. We have presented prior discussions on this site with regard to the perioperative management of the older patient. We have discussed risk assessment for falls, and we have discussed fracture management in the older patient. I'd like to talk about gait changes with aging in the older patient. I'm always interested when I meet new patients who have been seen elsewhere in asking them whether or not they were actually evaluated for gait by their prior treating podiatric physicians or MDs or DOs. And it is just absolutely amazing how many patients have never been evaluated weight bearing. And I think if you're listening to this now, and you are a podiatric physician and you have not been having your patients stand and walk, I think you're missing an opportunity to improve patients' lives. I think about the practice of podiatry that we are all in, and we want to have a meaningful practice, and certainly evaluating the older patient and gait problems that they may have, and assisting in mobility is something that we can all contribute to. Loss of mobility is a terrible thing. It means loss of independence. It means loss of ability to care for oneself. And there are some patients, I think, that we can help, and we probably don't teach enough in terms of evaluation of gait in the older patients. We know that gait and balance disorders are common in older patients, and we have discussed this on this site previously. We know that lack of mobility, falls, loss of independence has been associated with increased morbidity and mortality, loss of ability to walk with reduced functional levels. And I think annually, as podiatric physicians, we should ask about falls and examine patients, observe them walking, and see whether or not we can make some contribution to quality of life, either directly by our direct intervention or indirectly by referring these patients into the areas of healthcare that would benefit them. All of you have the capability of doing this, you all have the knowledge to do it, and it's a matter of really getting you involved in doing this. I remember as a student at the Pennsylvania College of Podiatry, and my biochemistry professor in 1973 was Michael Scheff. He was a brilliant man. He actually worked with Krebs of the Krebs cycle, if that doesn't bring back some horrible memories for everyone listening. And he had mentioned one day casually that we probably don't appreciate how complex the activities are that we go through every day. And he said, just think about the complexities of driving a car at high speed and changing lanes and passing someone and cutting back in, and all the many neural processes that are involved in that activity. And we really don't think much about that in terms of balance and gait, but really these are very complex ongoing processes in our bodies. We have static postural reflexes that are involved in standing. As we're walking, we have anticipatory postural reflexes as we're walking, getting ready to contact the ground, lifting the next foot, looking at the supporting surface, making appropriate adjustments. We have reactive postural reflexes and feedback mechanisms going on entirely. So normally when we walk and adapt to the environment, we are absorbing spontaneously information about our environment, our body position. There are proprioceptive inputs, there are vestibular inputs. We're incorporating visual pathways. We integrate this information, interpret this information. We respond with appropriate muscle action, joint positioning, appropriate forces applied for whatever actions required. So we are modulating these factors for optimal performance, and we adapt and select various options based upon requirements. And we really probably don't appreciate what a complex issue this is, so that normal standing and normal walking require sensory input, visual and vestibular, as well as proprioceptive. And as podiatric physicians, we certainly can do simple testing, for example, for eighth cranial nerve function, for posterior column function, for sensory function. We have requirements for frontal lobe function, the motor cortex, basal ganglia, cerebellar integration for rate, range, direction, and force, and peripheral nerve function. And then we have biomechanical issues. And all of these things are involved in standing and walking, and require multiple levels of evaluation. As we get older, we have sarcopenia. That is to say, we lose muscle mass. We begin to develop an unstable gait, and falls increase in frequency as we get older. We have decreased ATP activity, again resulting in muscle fatigue and muscle weakness, contributing to falls and abnormality in gait. We have arthritic changes with cartilage deterioration, decreasing range of motion of lower extremity and upper extremity joints, increasing joint instability and osteoarthritis. And of course, we have osteopenia and osteoporosis. There are also mental changes that occur as we get older, and we know that cognitive function and other mental functions such as inductive reasoning, spatial orientation, perception, our verbal abilities, our memory all decline with aging. And again, this is going to influence our gait, our ability to stand and walk. So the typical findings we have in the older patient is more of a stooped posture. We have a shifting of the center of gravity. This places the patient at a greater risk for falls. This is compounding the sarcopenia that's present, decreased muscle strength and decreased muscle tone. So as we age, we certainly acquire a propensity toward falling. The typical gait changes that we observe with aging include decreased stride length, increased cycle time. We have decreased cadence, cadence meaning the number of steps that we take, for example, per minute. We have an increased duration of the stance phase of gait. We walk with a reduced speed. We have decreased range of motion in our hips and in our knees, and generally a reduced swing phase, so that these changes with changes in stride, changes in walking speed, step length, and so forth, all are observed with aging. There is a relationship between those changes that we note in speed of walking and the success patients have in day-to-day activities. We know that patients who have a slower walking speed tend to be more dependent in activities of daily living and independent activities of daily living. These are patients more likely to have problematic health issues and be hospitalized. These are patients that require more interventions to reduce the risk of falls. When we are involved with major illnesses and reconstructions in patients who walk slower, these are patients who are more likely that are going to be discharged to skilled nursing facilities rather than going home. They're more likely to require gait assistance at home with walkers and canes and tend to be more limited community ambulators. These are the patients that have more difficulty visiting us in the office. Patients with a greater walking speed tend to be more independent in activities of daily living. They tend to be healthier and less likely to be hospitalized, less likely to have adverse sequelae and events occur in their lives. They're more likely to be independent and be discharged to home rather than a SNF or assisted care facility. They're more likely to be independent and community ambulators. So we have differences in gait between those who are older and those that are younger, and we see these progressive changes between the young and the old over the years, with our older patients again having more of a kyphosis, more of an anterior lean, more of a shifting of the center of gravity, and all of the changes in cadence and stride and stance phase and swing phase. And these changes that occur as one gets older are very well documented in the medical literature, and certainly all of these changes have been confirmed and are available for study by any interested individual. And it's always surprising to me how a little gait is actually studied by podiatric physicians and podiatric surgeons. We have basic definitions, I think, that are familiar to most people, such as the time of double limb support, swing phase, and stance phase. Again, cadence meaning the number of steps taken per minute. We also look at issues such as stride length, which again is shortened as we get older, and velocity of gait, again, which lessens as we get older. So we have this entity called senile gait disorder, and we want to observe this as podiatric physicians, and this is a disturbance of gait that is occurring in the older patient that cannot be explained by the presence of some neurologic or arthritic or other disease. So as we get older, our gait becomes slower, it becomes more broad-based, it starts to become more shuffling, and it becomes more cautious. And we want to observe the patients coming to our offices, make note of whether or not they have an abnormal gait. And if they do have an abnormal gait, we want to either refer these patients for evaluation of that, make some recommendation to the primary care physician, or we may want to do that evaluation ourselves. Again, the biggest issue in my mind is whether or not one has the time and interest to truly evaluate patients with gait abnormalities, because there are many factors that are involved here. Again, from a sensory standpoint, these can be visual issues, they can be vestibular issues, they can be due to, say, neuropathy, it can be due to myelopathies. There may again be a patient who has sustained a significant fall, surgery and hospitalization in the past. It may be due to general deconditioning and muscle weakness. It may be due to arthritis. So we really have a variety of factors to be considered here, and one can certainly take the time to evaluate these factors. You certainly are within your scope of practice as a podiatric physician to evaluate patients for these problems and initiate appropriate therapies if you have the time and competence to do so. When we look at falls, and again we have a prior session of the Center for Podiatric Education available to you discussing specifically this issue of falls, we realize that there are a variety of common disorders and there are a variety of uncommon disorders that can account for a issue of falls in the older patient, and it is an eclectic variety. And as you would imagine, this can range from simply having too much clutter in the home or apartment or living quarters of the individual. It may be associated with poor footwear. It can be associated with sensory ataxia or simple lack of sensory feedback. One of the more commonly missed problems would be normal pressure hydrocephalus, something we'll speak about a bit. We have patients who, and I see this quite commonly, who have had a stroke and really go unbraced. Their contractures and deformities go unattended, and I just think it's just awful when I see these patients who have had initial care following their stroke, and there's really no aggressive efforts being made to keep these patients mobile. Again, it may be something such as orthostatic hypotension, where a patient has autonomic neuropathy, or perhaps they're on a medication that's affecting their ability to adjust their blood pressure from lying down or sitting to standing up. So we can look at the drugs these patients are taking, we could look at the diseases with which they've been diagnosed, and try to assist in coming up with some reason why these patients are having falls. So the assessment of a patient for falls is multifactorial. There are many other considerations. Again, medication effects I've mentioned. We don't want to forget that a drug intoxication or alcohol use is not something that is rare in the older patient. It may be their home environment, and certainly one area where we can contribute in a positive way is the patient that has an antalgic gait, perhaps by taking care of some painful foot problem, recommending appropriate accommodative and palliative care, providing appropriate shoe selection. All of these things can indeed not only improve quality of life, but help interdict the possibility of a fracture and perhaps even be life-saving. In the discussion on fall assessment, we talk about the get up and go test, and this is something that I've incorporated into my office, and I do this routinely. It is simply done, and certainly anyone here can do this test, and it is something that is very accepted in evaluation of the geriatric patient. Patients who have difficulty with the get up and go test should be referred for more detailed evaluation, and we can take the role of guiding these patients for appropriate evaluation and care, and hopefully again reduce their risk of falls. So the test is easily done. We ask the patient to get up from the examination chair or a chair. We ask them to walk 10 feet, turn around, and return to their chair. It's as simple as that. And we observe them get up, and we watch the difficulty or lack of difficulty with which they rise from the chair. Do they require the assistance of the arms of the chair? Do they fall back? Do they have a steady gait? Do they take more than 3 steps to make the turn to return back to their chair? So we're assessing 10 feet of walking. In general, patients who can do this in less than 10 seconds tend to be independent. They tend to be freely mobile and have a lower risk of falls. Patients that can do it in under 20 seconds generally are independent. When we get over 30 seconds to perform this test, it's felt that these are patients that are at more significant risk for falls, and between 20 and 29 seconds, generally increased risk for falls. And again, these patients should be looked at in terms of medications, concurrent diseases, arthritic changes, general health, neurologic status should be assessed, and perhaps we can help by referring these patients for appropriate evaluation. In terms of looking to patients that have other than rather typical senile gait disorder, and want to evaluate these patients for their gait problems, sensory deficits are not at all uncommon, and certainly even a uncomplicated neurologic examination performed by the podiatric physician can uncover many of these sensory deficits. Myelopathies, both cervical and lumbosacral, are not at all uncommon. Certainly we see many patients with Parkinson's disease. and patients with normal pressure hydrocephalus, so-called wet, wobbly, and wacky patients. And we'll talk a bit about that. Neurologic gaits specifically, we have hemiplegic gaits and spastic gaits, gait associated with stroke and certain spinal cord injuries. We have drop foot gait, we have slapping gait that we see with significant sensory neuropathy, including diabetic sensory neuropathy and idiopathic neuropathy. We may have ataxic gait from cerebellar dysfunction. We may have a waddling gait or Trendelenburg gait due to hip musculature weakness. And we may have so-called magnetic gait with the patient suffering from normal pressure hydrocephalus. We have, of course, the classic Parkinsonian gait. And here again, there may be patients who have neurologic gaits secondary to pain. There are many things that you as a podiatric physician can do to improve the quality of life of these patients. And I will say something else. Here again, I think it's a chance for you to be a doctor, not just a foot person. And I think the perception of the patient and family and other members of the healthcare community are different when they view you, when you take a more proactive role in assisting and helping these patients. We can assist with orthotics, we can assist with braces when appropriate, and by braces I mean legitimate, fact-based braces. There are no braces that improve balance. So when we see advertisements for, quote, balance braces, you should understand that not only do we not have braces that are specifically approved to improve balance and lack studies, but that third parties don't pay for balance braces as such. Where braces are helpful is where we have specific deformities that are affecting gait that we can improve by reduction of that deformity with the use of a brace. A classic example would be a drop foot brace, and I prescribe a large number of drop foot braces. I send these patients out. Certainly you have the option of not only prescribing but dispensing these if that's what you choose to do. I send these patients to rehab centers and pediatric facilities and so forth, where they have more expertise than I would in determining the specific drop foot brace to be used. But it's surprising how many people do not have drop foot braces. Either they've never been evaluated, never been prescribed, or you do see some people that simply will not wear a drop foot brace. Sometimes they've had a bad experience with older versions of drop foot braces. Particularly with spastic patients, Botox injections are frequently helpful. Referring patients for group exercise programs is very, very helpful. And there are times when surgery is indicated to reduce significant deformities, to strengthen weakened muscle units. We can provide stabilization of unstable joints or relief of pain by arthrodesis procedures or osteotomies. We can refer patients to physical therapy for balance training, muscle strengthening, and gait training, and I do this routinely. We could utilize topical analgesics or oral analgesics. We can utilize muscle relaxants, and sometimes we can help treating underlying disorders, such as neuropathy from compression syndromes, or neuropathy from metabolic or endocrine disorders such as B12 deficiency. So at a minimum, we want to look at patients, recognize the presence of gait disorders, and make an appropriate referral. At a maximum, we can get involved ourselves and directly help patients by interventions. So we have a number of more common neurologic gaits. This includes post-stroke hemiplegia, the classic Parkinsonian gait, patients with cerebellar ataxia with a more broad-based wobbly gait, patients that have a foot drop, or patients that have sensory ataxia, which again we see not uncommonly in the diabetic patient with advanced neuropathy and a sensory ataxia. With regard to sensory deficits, obviously proprioceptive feedback, sensory feedback is going to be important for normal gait. This can be typically associated with a peripheral neuropathy. It can be associated with a myelopathy. At times it can be associated with eighth cranial nerve dysfunction. We may want to ask about lighting and clutter about the home because poor lighting and uneven ground can be very problematic with visual deficits. And here again, if we can identify an underlying disorder and make an appropriate referral, we can help some people or refer them for gait training. So one area where podiatric physicians certainly can play a role is in the detection of peripheral neuropathies. And the minimal neurologic examination should include checking reflexes, checking sensation, and checking muscle strength. And this is something that is a solid part of my practice and certainly should be part of your practice also. My old professor of neurology at the Pennsylvania College of Podiatry, Henry Schuda, used to tell us there are 3 questions you ask with reference to neurology, and I've always followed his advice through over 40 years of practice. The first question is there a problem? So before we rush and try to identify the etiology, we say to ourselves, is there in fact a neurologic problem existing? If you establish a neurologic problem by virtue of checking muscle strength and reflexes and sensation, then the next question is, where is the problem? Is it in the peripheral nerve? Is it in the leg? Is it in the spine? Is it central? And then lastly, you identify the nature of the problem. So you say, is there a problem? If so, then figure out where the problem is. And then lastly, what is the problem? And here again, depending on your level of interest, you are going to have more or less involvement. I think at a minimum, you want to determine, is there a neurologic problem present? And if so, you want to make an appropriate referral. Sensory deficits are common in older patients and will contribute to gait abnormalities and contribute to falls. About 1 in 4 people over the age of 65 to 75 have a significant sensory deficit. Over half the patients over the age of 85 have a significant sensory deficit. This tends to be seen with increased frequency in patients with lower income, patients who have been in the service, patients who have a higher BMI, and certainly 2 common issues would be diabetes and vitamin B12 deficiency. And there is absolutely no reason why you cannot be checking reflexes, checking vibratory perception, joint position sense, light touch, and temperature perception. We are all familiar with the common gait presentation of the hemiplegic patient who has had a stroke and an equinovarus foot type with lack of pelvic motion, lack of knee motion, and generally dragging of the foot, and lack of a trailing limb, and appropriate gait instability. And there are many things that you could do to assist these patients. We want to first of all remind the patients that there will be some initial recovery over the first 1.5 to 2 years. And you can take a look at these deformities and try to minimize the contracture and deformity that's going to be residual. And you can do this by exercising, by stretching, by splinting, and by appropriate bracing. You can refer these patients for rehab or physical therapy. And here again, it is surprising how many of these patients have not been referred for or are not continuing with ongoing therapy. There are things you most certainly can do to help. Botox injections, again, to reduce the spasticity and make bracing more effective. And there are certainly surgical considerations ranging from tenotomies to tendon lengthenings to tendon transfers. So there are many things that you can do early on and later to improve the patient with a spastic hemiplegia. I think one of the more interesting problems that we see, ranging in 6 to 8% of our elderly patients, is normal pressure hydrocephalus. And there is a mnemonic for this, and that is wacky, wet, and wobbly. This is a problem that occurs with increased buildup of cerebral spinal fluid in the patient, and can be treated in a number of ways, including, when necessary, ventriculoperitoneal shunt. So this is a patient that has a history of urinary incontinence. They have some degree of dementia. And these patients seem as though they have increased intracranial pressure, but generally their cerebral spinal fluid pressures are normal or only minimally elevated. Now, what is going on in these patients is that there's decreased absorption of their cerebral spinal fluid by the arachnoid villi lining the ventricles. So what happens is there's increased pressure of the cerebral spinal fluid because it's not being absorbed. This increases force against the brain. However, in order to reduce that force, the area of the ventricles increase. The ventricles increase in size so that we have a reduction, a compensatory reduction in cerebral spinal fluid pressure. And that's done by virtue of the dilation of those ventricles. So the fluid pressure is normal or slightly elevated, even though we have increased pressure of the ventricles up against the brain structures. So this is the pathology of a normal pressure hydrocephalus, and generally the phrase wet, wacky, and wobbly is applicable as we have patients that have urinary incontinence. They tend to develop cognitive impairment, and they have gait instability, and this more or less constitutes the classic triad of normal pressure hydrocephalus. We see that these patients walk with a decreased cadence and a decreased step length. They don't raise their feet as much. They tend to walk almost with a cerebellar gait, as you see illustrated here, with a wider, broad-based gait. They tend to walk with a pronated foot structure. They have a tendency to easily fall backwards or retropulse. It takes them multiple steps to make a turn. And one of the ways you can detect this early on is with your get up and go test. And when the patient walks the 10 feet and turns around, you'll see that they'll take multiple steps with a broad-based gait, have some perceived balance issues as they make that turn, and this can raise the specter of normal pressure hydrocephalus. There may be some diagnosis of dementia or some cognitive impairment in that patient, and you certainly have every freedom as a doctor to ask about urinary incontinence. They may be hyperreflexive when you evaluate them, and again, you may mistake this for a cerebellar dysfunction or Parkinsonian gait. So the classic triad is wacky, wobbly, and wet for normal pressure hydrocephalus. The differential diagnosis would include gait associated with Parkinson's disease. It may include Alzheimer's disease because there is cognitive impairment that does occur with normal pressure hydrocephalus, and certainly other forms of dementia, such as vascular dementia and Creutzfeldt-Jakob dementia may also be involved. The subject of normal pressure hydrocephalus brings us to the fact that there are other neurologic disorders with which gait abnormalities can be associated. One of the more common ones is certainly Parkinson's disease. There are cerebellar ataxias that we see, degenerative dementias, as we've mentioned, such as vascular dementias, Alzheimer's disease. And Again, I think the biggest issue is to watch these patients walk, watch them during the get up and go test, and if you suspect that there is strong evidence that you're visualizing of a gait abnormality, to make an appropriate referral. Parkinson's disease is something that we see and not at all infrequently as podiatric physicians. And here again, there are things we can do to help improve the gait of these patients. As my old professor, Dr. Schutte, used to say, the three components of Parkinson's: tremor, rigidity, and bradykinesia. The onset generally is after the age of 50. There tends to be a stooped posture. We see pill rolling, tremor of the hands. We tend to see a less expressioned face, a more blank looking face. When we watch these patients with regard to bradykinesia, they don't tend to swing their arms very much when walking. They don't seem to blink their eyes very much at all. And again, they tend to sit still with that tremor but don't seem to move their extremities very much. The tremor occurs while resting. And again, if we look at their hands, we may see a classic rolling, pill rolling tremor. When we move these patients through range of motion, we find that they're generally stiffer in all directions and have a cogwheel, jerky mobility to these joints when moving them. It is said that Parkinson's disease is far less common in African Americans. However, I certainly have seen patients who are black who have Parkinson's disease. Parkinson's disease does go through various stages. Initially, we see tremors just on one side of the body, and we see some early shuffling gait, but nothing dramatic. Over time, the tremors spread to both sides of the body. We begin to see changes in reflexes and general stiffness. We tend to see eventually the need for assistance getting out of chairs, assistance when walking, assistance in retrieving various objects, and eventually we have advanced stage Parkinson's disease. Now, we know that Parkinson's disease involves a lack of dopamine. Typically, the basal ganglia will act to reduce the activity of the reticular activating system, to reduce the stimulation of muscles, so that typically the basal ganglia will dampen the effect of the reticular activating system on the spinal cord, and as a result control muscle activity. When we lack dopamine, when we have disease, for example, in the substantia nigra, then what happens is we don't have basal gangliar inhibition of the reticular formation. This means the reticular formation is more active in stimulating the spinal cord, as a result of which we have increased muscle activity and muscle tremor. That is why efforts to replace or stimulate the production of dopamine are so critical in the treatment of patients with Parkinson's disease. The typical Parkinsonian patient has a forward lean or stooped gait. There's a lack of motion of the arms and body in general. They have reduced arm swing. You'll see slight flexion of the hips and knees and a short shuffling gait, very much like a character that you might see on the old Carol Burnett show. That was where Tim Conway would perhaps show you that shuffling gait with trembling. Some patients with Parkinson's disease, because of their forward shifting of the center of gravity, start to develop festination, where they start walking more and more rapidly in an anterior forward direction, or they tend to fall backwards when trying to stop, so-called retropulsion. Again, recognition of the Parkinson's gait early on can lead to an earlier referral and hopefully appropriate interventions to assist these patients. We certainly can make recommendations for appropriate gait assistive devices. Fear of falling is certainly an issue. Patients may sustain an initial fall. They then self-induce inactivity in their lives that develops into increased weakness and further instability, and they may sustain an additional fall, which only increases their fear of falling even more. There is so-called fear of falling syndrome as a result. So we may see patients with a very protective gait. They tend to walk with a very slow gait. They're always seeking to hold on to some structure, looking for some support. They try to avoid walking if at all possible. And this is something that requires appropriate referral for therapy, psychological therapy, physical therapy, standing and gait training. And here again, our role is to talk to the patient, recognize that they do have a fear of falling, that they're losing independence, that they're becoming weaker because of this, and getting these patients referred to appropriate health care facilities to deal with this problem. In looking at peripheral nerve injuries, we have, of course, neuropathies with numbness and weakness, and here again, this is something that we can certainly detect, and at times we can participate in the treatment of these problems. We have radicular disorders where we have disease of the spinal cord roots, and here again, this can include numbness, it can include weakness, and this is something that we can assess with a proper simple neurologic examination in the office. And then there are myelopathies where the disease is not in the peripheral nerve, it is not in the spinal cord root, it is in the spinal cord itself. Generally, in addition to numbness and weakness, there may be some general stiffness and some degree of incoordination. We want to remember the basic tracks that we all learned as students, and in particular with myelopathies, we want to pay particular attention to the lateral cortical spinal tract, the so-called pyramidal tract, and we want to pay attention to the vestibulospinal tract, which again plays a major role in muscular control. Now, patients can have disease in the cervical spine itself with cervical myelopathy resulting in weakness in the legs, loss of balance, decreased motor skills of the foot. We may even see what appears to be upper extremity disease with some degree of spasticity, paresthesia, dysesthesia, and hyperreflexia. So that in the presence of a patient who's complaining of weakness in the legs, loss of balance, we may see some increased reflexes, and we may want to consider whether or not there is pyramidal tract disease or vestibular tract disease, vestibular bulbous disease, and ask about neck pain, ask about upper extremity symptomatology, and here again, refer the patient back to the primary care physician or to neurosurgery or orthopedic spine to have these patients appropriately evaluated. We see many patients in our offices with spinal stenosis in the lumbar spine, and it is said to occur in up to 25% or more of patients over the age of 65 who are ambulatory and independent. These patients will have radicular symptoms, and so we may ask about pain radiating down the leg in association with chronic low back pain. These patients may have weakness, and we can do tests such as straight leg raising test. These patients frequently will have symptoms of cramping in their legs when walking. It sounds at first glance as though it may be claudication, but in fact these patients have pseudo-claudication. And one of the keys is to ask the patients what they do when the symptoms occur. Patients with vascular claudication tend to simply stop walking and stand still, and Patients with pseudoclaudication due to spinal stenosis will tell you that they either sit down or they lean forward in order to release pressure on the intervertebral nerve roots, the intervertebral foramina. And they give a more neurologic description of their symptoms so that we hear words like tingling, and we hear a description of radicular symptoms. So with spinal stenosis, we may see a sensory deficit, we may see decreased reflexes. I always ask the patient about bladder or bowel dysfunction. We may have disease involving the posterior tracts in the cord, the dorsal root ganglia, so we may want to check proprioception. We may want to do a Romberg test and check patients for stability. We see patients with drop foot. I know I do an awful lot in my patients, and I see this not infrequently, not only after injuries to the deep peroneal nerve, or rather peroneal nerve at the fibula, but we see this after hip surgery, after spine surgery, after knee surgery. We see it when the deep peroneal nerve has been injured by casts and so forth. And it is surprising to me how many patients have an uncompensated, untreated drop foot deformity. It may be due to weakness of the dorsiflexor muscles. It may be due to hypertonicity or spasticity of the posterior calf muscles. It is not at all infrequent in patients with peripheral neuropathy, and it's one of the reasons that decompression of the common peroneal nerve is commonly performed in the surgical management of diabetic neuropathy. We can see it in multiple sclerosis patients, and again, we see this not infrequently, although they tend to deny it was a relationship, but we tend to see this not at all infrequently after hip and knee surgery. There are a variety of manners with which patients compensate for their drop foot. This leads to an unstable gait. It leads again to a decreased frequency of walking by these patients. And here again, as a podiatric physician, there are many things you could do to help these patients. You could determine the etiology. You could recommend drop foot bracing, which I frequently do. You can refer these patients to physical therapy. At times we will go ahead and do a gastrocnemius recession or an Achilles tendon lengthening to make the braces more effective in those circumstances where you feel a significant contracture is limiting the effectiveness or the ability of the brace to work. There are times when tendon transfers are appropriate, when Botox injections are appropriate, if there's, for example, overriding of the posterior musculature, and ankle arthrodesis or decompression surgeries may be appropriate. Ataxic gaits are due to cerebellar disease. My old professor, Dr. James Ganley, used to tell us how to remember cerebellar dysfunction, and those would be abnormalities of rate, range, direction, and force. And these are patients that have a wobbly, broad-based gait, and if you didn't know better, you'd think the patient was drunk. It is part of the class of ataxic gait disorders. In addition to cerebellar disease, we can see an ataxic gait with posterior column disease where we've lost vibratory perception, where we have lost joint position, sense. Certainly we see this in some patients with a peripheral neuropathy. This may be from diabetes or chemotherapy or AIDS or it may be drug induced. And you can see this obviously with 8th cranial nerve disease and the vestibular disease. Now, in testing for ataxia, the classic test is the Romberg test. And what we do is we have the patient stand with their feet together and their arms at their side with the eyes open and then the eyes closed. And you look and see if the patient maintains their balance or develops a sway. If they have a peripheral lesion, they will tend to sway to the side of the lesion. They will show general instability. If they have a central lesion, you can also have the patient march in place with their eyes closed and their hands at their sides, and you can see whether or not they start to rotate, and if they do, they will tend to rotate toward the side of their cerebellar lesion. If you want to do a so-called sharpened Romberg test, you have the patient raise their arms and hands and fold them across their chest. They then stand with their feet in tandem, and here again you want to test their balance. I'd recommend that you stand behind them and be prepared to catch the patient when doing the sharpened Romberg test. Time doesn't permit a detailed discussion of cerebellar anatomy, but the examination is fairly straight away. You ask the patient, not only do a Romberg test, but to see if they could walk in tandem gait, see if they could touch one extended finger to another. You ask them to rotate their fingers down on the ground, rather on the desk, touching their fingers to the ground sequentially. You can see whether or not they can do the finger to nose test. You can look for nystagmus. You can do rebound testing, glabellar testing. There are a number of rather classic tests that can be done for cerebellar dysfunction. Lastly, looking at gait assistive devices. You want to ask yourself, is a device appropriate for this patient? Do they require one or two arms for their assistance? And there are certainly schema that can be followed depending on the individual patient, their weight, their size, their ambulatory demands, their upper extremity use. So you have many options, including hemi walkers and quad canes and offset canes and walkers to help patients. One of the things you kind of hate seeing is something like this. You want to make sure that when you prescribe a cane, whichever type of cane or gait assistive device you think is appropriate, that is appropriately fitting. You don't want canes that are too long, and you don't want canes that are too short. Generally, the length of the cane should be such that the top of the cane is parallel to the greater trochanter, so that you don't want a cane too long or too short. And canes can be prescribed, and depending on the height of the patient or the height of their greater trochanter, actually, you can appropriately prescribe the needed length of the cane. There are a variety of different walkers that are available depending on your findings in any particular patient, and again, there's no reason why you cannot be prescribing these. So in looking at gait abnormalities, you want to evaluate these patients for any variety of disorders that we have discussed. You can do a mini neurologic examination, or at a minimum recognize these gait abnormalities and refer these patients appropriately. So in summary, gait is a part of being a podiatric physician and surgeon. Recognition of gait abnormalities is helpful for improving the quality of life of many patients. It is important for preventing falls, preventing fractures, and in some cases saving lives by preventing those falls. But you can't do this if you don't watch the patients walk. You can't do this if you don't observe their gait and make appropriate notes. So at a minimum, a questioning, observation, a simple get up and go test, and a basic neurologic examination will be helpful in recognizing these abnormalities. And I think when you do these things, it gives you a more meaningful purpose to your practice. Thank you.